to yesterday, without doubt. So first of all, do we have any apologies?
I've got one from Linda Benny.
Okay. And any declarations of interest? Yeah. So we go to the minutes of the meeting held on the 26th of November. And what I'll just ask is if there are any corrections or any comments anybody wants to make on the minutes. No? Well, in that case, I'll be happy to approve the minutes. Give me a nod. Thank you. And moving on to the rolling action log. And I don't know whether anyone has anything they want to say around the rolling action log. I know there's a couple of things that are complete already. One for June and one for March. So these all seem fine to me, but I don't know if anyone has anything they'd like to add. Great. Well, in that case, we'll move on to the first substantive item on the agenda, which is the Adult Support and Protection Joint Inspection Report. And I believe Gordon has arrived. Gordon, and I believe you're presenting the report.
Sorry, Chair, I was fiddling about with on and off buttons there. My apologies. So I haven't been able to access the final version of the report. I don't know if that's available in front of members, so I can just talk to the report myself. Yeah, okay. So as members will be aware, there was a joint inspection of adult support protection practices, procedures over the whole of Forth Valley conducted in the latter part of 2021. Each local authority area had its own inspection, but for health and for police, it was 3 inspections at one time. The report on Falkirk is in front of you. The inspectors from Inspectorate Constabulary, Health and the Care Inspectorate looked at 50 cases which had been taken to investigation and a number of others which had been to inquiry. They looked at the quality of the work, the key processes that the partners had engaged in throughout those episodes. They also looked at our performance in respect of adult support and protection throughout the pandemic. The period of inspection, the papers that they looked at were the 2 years prior to May of last year. From the inspection, they gave us a feedback on key strengths and areas of improvement. Overall, the inspectors felt that the performance of Falkirk was there was more strengths than areas for improvement, and they had confidence in both the processes and the leadership of the partnerships in relation to adult support and protection. There is an improvement plan we need to put together. We're working on that just now, and we will present that in due course. I would like to give credit to our lead officer in the partnership, Gemma Ritchie, who did a great deal of the heavy lifting on this, working closely with partners in police and health. It is one of the most crucial areas of activity for partnership, for police and health indeed as well. As I say, we will be putting together an improvement plan. The areas of improvement that were identified were areas that we were already aware of, and the inspectorate acknowledged that, and I don't think that there's anything in the improvement plan or improvements areas for improvement that came as any surprise to us. Sorry about the brevity of that. As I say, I don't have the paper in front of me myself, so happy to answer any questions.
Thank you very much, Gordon. I think the report's very interesting, very clear information on the strength and areas for improvement. I think it's heartening, I suppose, for all of us to hear of some of the strengths of the partnership in terms of leadership, communication, governance and monitoring of risks. And I think that the point about the robust response during the pandemic, and I know that those stronger links with the community and the third sector definitely helped. And I think those identifications of adult support issues, and I also note the areas for improvement. And I suppose my one question around it is around the improvement plan, and probably the time scale for that, and probably a practical aspect of adding to the action log, so that we can come back to it once that work's underway.
Absolutely, yes. So I will need to come back to you, I'm afraid, on the date for the improvement plan to be submitted. I'm sorry, I don't have that in front of me just now.
Okay, so I guess we can take that as away as an action for the action log for that time scale. Does anyone else have any questions or comments they'd like to make? Tricia.
Thank you, Chair. The Adult Support and Protection Committee will oversee the implementation of the action plan, but I propose that we would report back in progress also as an update to Clinical Care Governance Committee. Thanks.
Thanks, that's really helpful. Any other comments or questions? Sarah.
Thank you, Convener. Really just to highlight to committee that this is a positive report for Falkirk's partnerships, and ultimately the inspections were requested by ministers seeking assurance from all partnerships across Scotland in relation to key processes and leadership around adult protection, as Gordon has outlined. This report has provided that assurance to ministers and also should be considered by this committee to provide that same assurance. It's an important report, and it's right that we focus our attention now to the work of the improvement plan, and that work is underway. And will be absolutely appropriately considered through committee and through the Public Protection Chief Officers Group, and can certainly be reported back for sight by committee, as Patricia says. But this is an important report saying lots of really positive things about how all of our workforce who are at the helm of protecting adults in Falkirk are responding to needs, and how they responded to those needs throughout the most difficult of 2 years through a pandemic. So just for a moment, I really wanted to recognise that, and that we do feel as a leadership group too, that we want to ensure that that is heard amongst everybody in the front line. This is their report, and it's a report that people should hopefully recognise themselves in, and certainly one that provides good assurance for everyone. So thank you, Fiona.
Thanks, Sarah, and for setting out that sort of line of sight. And I think, for this committee, it's around assurance rather than monitoring the action plan. That's for other committees and groups. So thank you for that. Margot, would you like to come in now?
Yes, just a quick apology to Gordon if it's too early to ask, but in the conclusion it's talking about the sort of consultation of service users and carers, and I wondered if there was any detail on that could be shared. The plans.
Thank you. There is there is an extensive plan being put together for consultation with service users and carers. As I said, Gemma Ritchie, the lead officer, will be leading on this, and I know that there will be there are going to be events set up for consultation with service users. I'm sure there will also be surveys in relation to that as well. Just Chair, just one point, the improvement plan, I've checked through the letters from the Inspectorate. The return date is the 23rd of March, just for noting that.
Thank you very much. Yep. Does anyone else have any other questions or comments? Margaret, did you want to come back? No, the hand's gone down.
Hand is down.
Just 1 second. So are we happy to, I've lost my page here. Are we happy just to, we've had our opportunities for consideration or comment. Thank you for bringing the report, and we look forward to hearing more information around it as the improvement plan develops. I'd like to move on now to the Duty of Candour annual report, and I believe that's you, Sarah.
It is. Thank you very much, Chair. So this report presents the Falkirk Council Duty of Candour Annual Report 2020 to 2021, and that can be found at Appendix 1. All health and social care services in Scotland have a duty of candour, and that is a legal requirement, meaning that when unintended or unexpected events happen that result in death or harm as defined in the Act, the people that are affected understand what has happened and that they receive an apology, and the organisations learn how to learn from those experiences. An important part of this duty is that we provide an annual report about how the duty of candour is implemented in our services. Section 3 of the cover report outlines the legislative background to duty of candour, the relevant outcomes that relate to it, and the organisation's responsibilities within it. Local authority chief social work officers have a responsibility to publish an annual duty of candour report, and therefore go on to notify the Care Inspectorate that that has been done. So in future years, the Falkirk Council Duty of Candour report will be reported via the Chief Social Work Officer annual report. That happened this year for the first time, and it was presented to Falkirk Council in December 2020. At Council in December, it was agreed by elected members, and thereafter the entire report was submitted to Scottish Government. There were no incidents where duty of candour applied over the reporting period, but I would like to draw committee's attention to Appendix 1 nonetheless, which outlines what actions we've taken to ensure that our workforce are aware of duty of candour, and that you can see from the template what kind of activities are in place. So, Chair, the recommendations in this report are for committee to consider and comment on this report, and I'm happy to take any questions.
Thank you very much, Sarah. I think it's good to hear that there's been no incidents that would fall under duty of candour. But equally, having gone through Appendix 1, that strong focus on training and ongoing development for staff, alongside that strong information and governance is really important. So I'm going to open up for any comments or questions. Stephen.
Thanks, Chair. No, I would concur with that. It's gratifying to see we haven't had any, bearing in mind what we've just come through. But I suppose to just probe that a little bit more, and I see from the appendix that we are doing a lot of awareness. Sarah, is there anything else you think we should be doing just to make staff aware of those requirements? Because certainly in other environments that I'm in, I'm seeing an increase in complaints, for instance, that perhaps if duty of candour kicked in a little bit earlier, that would have prevented the complaint. I see Andrew's got his hand up right enough, so you might want to come in here.
Andrew?
Thanks, Stephen. Yeah, happy to. So I guess, as Sarah says, all public bodies have a requirement to produce this. We usually produce ours in a few months and publish in the summer. I don't know that it was a set cycle. So we have shared that before previously with the committee, and we usually do record some specific. This is organisational duty of candour. This is, as Sarah says, the legislative side of things. There's also professional duty of candour, which is where the individual clinician has been involved in an incident which requires full disclosure to the patient. And so there's that other side of it which we shouldn't confuse. And actually, our clinicians, the culture that we've certainly got in health, I think, is very good around that. We are very open and honest with people when things don't go well. But the organisational duty of candour is only triggered under very specific circumstances. Having said that, our numbers in health were low as well, and that is always begs the question: is that are we getting it right at all different levels in terms of things like awareness and then triggering and making sure people have that question asked of them? Should this be considered as organisational duty of candour? So we did a big governance event last year in July. I say big, it was virtual on Teams, so it was only me and laptop. There was quite a number of people, 70, 80 people joined. And we talked about duty of candour, organisational duty of candour, tried to remind people what the obligations were and the system around it. We've built it into our incident reporting as well, so that people are prompted to say, is this organisational duty of candour? And we also have it as part of our SAR processes. So there are ways that in the health side that we've been thinking exactly the same as Sarah and others have been thinking in their side of things. How can we make sure that we know that this is the only number of duty of candour incidents that we need to report? We're planning actually on the health side to do a wee bit more work on that. I'm looking to bring together a short life working group because again, I just think it would be good for us to review our policies and make sure that we have everything exactly as it needs to be, because there needs to be very specific engagement with families around a triggered duty of candour. There needs to be an investigation that they're fed back, and it's just making sure that we've got all the resources we need to be able to deliver that and the awareness to do it. So I guess what I'm saying is that, yeah, we've got a similar position in health. It's not a huge number of official organisational duty of candours that are triggered. We are very open with patients through professional duty of candour, but we've got a kind of ongoing focus on it to try and make sure we are tweaking it and getting it right. Thanks.
Thank you, Andrew. Sarah, you want to come in on this as well?
Yeah, just to add just a little, a bit more. Thank you, Andrew. That was really helpful to hear your perspective there. Just really, Stephen, to point out that these are, because organisational duty of candour is very specific to the most serious of incidents, and just by way of reassurance, those really serious incidents would always come to the attention of a very senior manager within organisations. So whether it's within council, health and social care partnership, we would always have sight, and we would always be able to ensure that there is attention brought to the need to consider duty of candour in those incidents. So there is a check and a balance within that system. In terms of doing more, I think there's always more we can do in terms of ensuring that the learning for the workforce is meeting their needs. I certainly think that would be something that we could focus on this year. You'll see from the appendix that we have duty of candour awareness raising within induction for staff, but that ongoing refreshing, I think we need to go back and just make sure that that looks different and feels different every year. So there's something interesting in that will maintain this at the forefront of people's thinking. But just to provide you with that reassurance, there is always a check off, and more senior managers are very aware of duty of candour, and we'd go back and ensure that that was put in place. Thank you.
Thank you, Sarah. Andrew, want to come back in?
Thanks. Yeah, I just wanted to, as we're talking about it, more and more recollections. I think it was Stephen saying, everything we've been through. So one of the questions that was raised in the health side of things was a thing called nosocomial infections, and that's when a person comes into hospital without, in this instance, COVID, but because of just the infectivity, the contagiousness of it, they picked up COVID, and obviously occasionally that, especially at the beginning of the pandemic, could be really devastating for the patients. And there was a question that that given duty of candour is if someone has something unexpected which adds to their or compromises their outcome in very specific ways, would that trigger duty of candour for the organisation? So anyone that came into hospital, caught COVID as a result of being in hospital, maybe subsequently died or had their stay extended, would that be duty of candour? And that was a question that the collective medical directors took to the CLO. And the CLO advice was that would not be duty of candour, it would not be organisation duty of candour, because as long as what the circumstances that had given rise to the nosocomial infection were as a result of the implementation of Scottish Government policies. So if you're doing everything you can or everything you've been instructed to do, but because of the infectivity and the unknowns around that, there's still transmission of COVID, then that would not be seen as duty of candour. So that was a kind of, it was when Stephen mentioned about the fact that we've just come through the pandemic, I thought that's something that we have actually tried to explore and see if there's an organisational obligation to do that. CLO advice, really clear, it's not a duty of candour.
Thank you. Stephen, is that sufficient?
Yeah, that's great. Thanks very much for that. Cheers.
Thank you. Do you have any other questions or comments? None. Well, in that case, thank you very much for the report, Sarah, and Andrew, for your contributions as well on that. And I will move on to the next paper, which is Prescribing Proportionate Care Project, which is not easy for me to say. Is that Gordon coming in on that?
Yes, it is. Yes.
I was trying to find you on my screen.
It's not an easy term to. I struggle with it myself, I have to say. So you got the report in front of you. Members will be aware of the difficulties that we have been facing for some time in sourcing packages of care. They will also be aware that we've struggled to recruit staff. The care sector as a whole has struggled with this for some time. We have been looking for different ways to improve that position by recruiting staff, by embedding an enablement approach so that people are more independent and able to do for themselves. We've been looking at reconfiguring care routes to make the system more efficient, and we're currently engaging a review of occupational therapy services in order to make that as slick as we can. However, we also needed to look at the actual skills and the techniques that we were using to provide care for individuals, and indeed for their informal carers. And we have rolled out, we are still in the process of rolling out updated training in moving and handling techniques. That's what prescribing proportionate care is about. Essentially, it's looking to find the best way to move people who need assistance to transfer, for example, from bed to a chair, whatever, safely and as independently as possible. We have quite a number of individuals in the Falkirk area, over 250, who require 2 members of staff to help them to move, to get dressed in the morning, to wash, etc. And we believe that with using more modern techniques and more modern equipment, a substantial proportion of those people may be able to move, be able to transfer with possibly just 1 member of staff. Now, that's a good for a variety of reasons. Obviously, it reduces the number of staff that are required, and we can use those staff to support other people who are waiting for packages of care. But also, by getting the techniques better, it will give individuals that little bit more sense of independence. Instead of being dependent on 2 people coming to the house and assisting the transfer, they would only require 1 person, or indeed in some cases they might be able to move without some of the transfers without any members of staff. So there's lots of benefits to this approach, as I said, we've been working with a range of staff, occupational therapists, physiotherapists, etc., to try to roll out this approach. We're training those individuals to become across both health and the local authority and the partnership and independent providers to train more staff so we can increase the capacity across the system to support people and move them in the most effective and appropriate manner. There is an issue with getting equipment at the moment. I think previously the CGC was advised that there is a worldwide shortage of certain components, so we're struggling a little bit with that. But we're pressing ahead with the training to get staff teams set up to implement this as soon as possible, and hopefully benefit not just the individuals themselves, but also the wider health and social care system. Thank you.
Thanks, Gordon. I've been reading this paper with great interest. I think there's clearly some key benefits on improving consistency of care. I know from my experience over the years that consistency of care really is vital, about building positive trust and relationships. And so I think it's fundamental to delivering best care and support possible, and building up experience of the person and their needs and preferences. I think, for many people, the care workers are often the only people that they see on a regular basis, and we can't underestimate how important it is to have those consistent good relationships, because they really are friendships. And I think we can't underestimate that. I noted the point about reducing footfall, and that's probably quite a good point at the moment. I know from people that I speak to that sometimes people have been reluctant to have care services come into their house. So as we move forward, particularly around those people who have not yet got a care package in place, that may be a very important an important element. And I know from our work that often carers, they talk about their homes becoming Sauchiehall Street, which probably should be Falkirk High Street rather than Sauchiehall Street, but with multiple professionals visiting on a daily basis. So minimising those numbers coming in and the same people coming in, I think it's a really good thing. I've probably got a couple of questions about the working with individuals and carers on this, and with the staff on the change and how it will be communicated and discussed with individuals, because obviously there may be some concerns by people who currently have two members of staff who are supporting them, and there may be some anxiety around that.
Yeah, so if there are, it starts with an assessment. So one of our newly trained staff would be having a discussion with the individual and carrying out an assessment using the techniques that they have been learning over the recent weeks. They would be informed, and then informal carers, where appropriate, would be informed about this process. And we would be working with, so for example, if you were coming out to assess me and I had a care package in place, I would expect you to come talk to me about it and talk to my carers about it, and for the carers to be advised and shown how to use those techniques and any new equipment. And that's the process that we are going through. So we'll do an assessment, we'll look at that. In many cases, what you'll find, this has been trialled over something like 60 different areas across the UK, and on average, about 40% of people require less staff coming in to provide the care with transfers. But a lot of those visits will be longer because you've got one member of staff. So we come in, we talk about the approach, we talk about the consequences, what that will mean for the individual, and hopefully they will see the potential benefits that way. And as I said, we train staff in order to deliver the care, because some of the equipment and some of the techniques are going to be different from from what they are currently used to.
Thanks, Gordon. Does anyone have any questions or comments? Margot and then Roger. Margot, you're muted.
Right, sorry about that. It seems very much, my simplistic reaction is, right, it doubles the number of people that can be offered care packages, which with the current situation of delayed discharge because care packages cannot be put in place. I mean, it also, I think, impacts on unpaid carers as well, because at the moment a lot of family involvement in older people who are trying to help in these areas has to be improved, because they themselves, their health is suffering. All I would say is, you know, it sounds very good. It releases more people from hospital. And I was listening to, you know, Fiona's questions about continuity of care. I just wondered about the staff and how they felt about it. Do they feel more vulnerable just going in singly, or are they quite happy to have this situation?
So I don't want to oversell this approach. We're talking about possibly 40% of people who currently require 2 carers to transfer being, you know, after reassessment and introducing additional equipment, not requiring 2 carers, going down from 2 to 1. So it wouldn't be 250 people suddenly moving straight to one carer. As I was also saying, that although they will perhaps only require 1 carer, instead of the visit being half an hour with 2 carers, it might be one carer for 40 minutes. So it won't translate to, you know, a simple, there'll be 40% less carers, but undoubtedly it will benefit overall, that there will be people, there'll be staff time freed up in order to provide care for others who are waiting for care, and that's definitely one of the drivers behind this. In terms of staff approach or staff views on this, I think, well, speaking personally, anytime you introduce something new to me, I'm interested to know, but I'm slightly apprehensive. And I would imagine that across the staff teams as a whole, there'll be an element of that. Staff here, that's what their job is. They want to do the best for the individuals that they care for. But when you're introducing new techniques, or whether it's moving and handling or new processes generally, you do want to make sure that staff are fully on board with this. So part of the whole approach, as I was saying earlier, is to train trainers who can work with the staff and help them develop confidence in using these different pieces of equipment and the new techniques. For our in-house service, the partnerships in-house service, that process has started. We've started briefing people. We're arranging for training sessions to take place. But we're only, you know, at the start of this process. I wouldn't expect to be going out and talking to, you know, the majority of carers and being able to discuss the ins and outs of this approach. I wouldn't even try to say it. This approach, because we haven't got across to the whole staff group, but that will come in time.
Thank you. Roger? Roger, would you like to come in now?
Thanks, Fiona. I know this is often a bit of a tangent, but could I make a plea for plain English in the report? And this isn't specifically about Gordon and his report, but I think it's general. There's more jargon and management speak creeping into reports over the last year, or that's how I've felt it. So could I'll quote a little bit here just to just for Gordon's sake, in 3.2, there is a critical need for a significant culture shift around tasks and ownership pertaining to moving and handling. I mean, that to me isn't accessible language for the average person who these reports should be accessible to. I mean, even the whole prescribing proportionate care, the report is really about moving and handling rather than a sweeping thing about proportionate care. So please, I'm only focusing on this because of that particular quote. Somebody came to me and said, "What does that mean?" But generally, could I ask people to try and think about language which is not full of too much jargon, and as wherever possible. I know that sometimes that's really hard. Thanks.
Absolutely, Roger. Yeah, take that on board completely. We'll work harder on that one. Thank you.
Thanks, Gordon. Thanks, Roger. Stephen, you'd like to come in?
Yeah, I would totally concur with all the points made there. I suppose the one that I put my Daily Mail head on, and it's a very uncomfortable place to be, let me tell you. Sort of reading between the lines there, saying, you know, we're struggling to recruit. We know that. We are trying to use technology, which is the right thing to do. We're giving training to informal carers that are already under a lot of pressure. So I suppose that, you know, our media position around this as to why we're doing it, because I think reading between the lines, if you want to turn this into quite a negative story, I think you could do that. I think we're obviously doing this for the right reasons, to try and support as many people as we possibly can. But so I just wondered, are we aware of that, and, you know, should we get any kind of media inquiries? And I know it's a bit too early to find out exactly how the service users are going to be accepting of this, and how our staff, but we probably need to follow that up in a few months' time as well to see how it's bedding in.
Thank you, Stephen. Yeah, we'll take that away and we'll discuss that with our media advisor and have appropriate response ready if there are any inquiries. Be absolutely clear, and I think the committee has heard this. What we're doing here is adopting best practice. That's the approach that we're taking, and there are substantial benefits. But you're right, people can sometimes turn things around for whatever reason, and we'll be alert to that and have appropriate responses ready. Thank you.
Thank you, Gordon. Roger, were you coming in again? Or yes?
Yeah, okay, something that's just back on that point. Obviously, working on the coalface, speaking to both home care and to service users. There's some service users I think will be very much welcoming this approach. Others who will be quite anxious about it, and the same with carers. I think some will be very much welcoming this in certain instances, and others will be needing quite a lot of reassurance and support with it. So I don't think it's an approach which is going to create huge amounts of anxiety, generally speaking, but just some aspects of it.
Thanks, Roger. I would agree with that. Yep, absolutely. And that's why we're trying to get out to as many people and inform them about what we're doing and why, to try and alleviate some of those anxieties. Yep. Thank you.
Thank you, Gordon. Thank you, Roger. Is there any other comments or questions? No. In that case, thank you very much for the report, and we look forward to hearing more as it progresses. Thank you very much. And I'm now moving on to agenda item 8, which is the overview of local oversight arrangements, and I believe that's yourself, Suzanne.
Yes, thank you very much, Chair. The report presents an update and overview of our local oversight arrangements in place that are relevant to the HSCP, and through this report it's intended to provide assurance to the committee members of these arrangements. So the report's following the standard format that we've adopted for it in terms of providing updates on work of various committees and groups. At section 4 of the report, you'll note the work of the Public Protection Chief Officers Group and the most recent agenda items they considered at their December meeting. Work has progressed on the Chief Officers Group Risk Register, and the Chief Officers considered a detailed report outlining changes to the risks, mitigation actions and partners' risk and governance arrangements. And there will be exception reporting going forward for every COG meeting. In relation to the COG Risk Register, it was just to remind committee that you received a report in November outlining the strategic risk relating to the IGIB and the Clinical Care Governance Committee, and lead officers have continued to support work around this risk, to monitor that and to provide updates to the COG group and to Clinical Care Governance Committee, and we did give a commitment at that meeting in November to bring forward a further report later in the year around our risk arrangements. The COG also considered child protection and adult protection data and the key points from the Adult Support and Protection Joint Inspection as it was at that point. And obviously you've heard earlier on the report itself in terms of that being published now on the 8th of February. Workforce planning reported was also included around the work for Child and Adult Protection Committees, was considered, as well as wider issues around recruitment and retention practice and support for staff. In terms of section 5, we've got an update provided on the work of the Adult Protection Committee in the report, and the business items they too considered at the December meeting. Updates on the work of the 4 subgroups is also set out in the report. And I would just sort of note that the good progress being made across a range of areas that are included in those subgroups around areas such as training, audit and communications. Key achievements are noted for the Alcohol and Drug Partnership in section 6, and this includes work to refresh the ADP needs assessment. And just to note for committee, we'll continue to work closely with the ADP as we refresh our strategic needs assessment for the Health and Social Care Partnership strategic plan and review work around that. So we'll continue to work closely there. Work continues to implement the medication assisted treatment, so MAT standards, and 6.8 notes that the timescales for implementation have been revised with a focus on the first 5 standards that we're working towards. Importantly, progress with the naloxone programme and work with the Forth Valley Recovery Community and the Scottish Drug Forum is noted, and good progress continues to be made within the ADP delivery plan priorities, which has been shared and reported to various partners over the recent months. Section 7 provides an update on the NHS Forth Valley clinical governance arrangements, including their respective agenda and updates considered. And we've noted in the paper that agendas for their business meetings are structured and adapted from the Vincent framework, and that gives assurance on safe, effective and person-centred care. The report has a section as well on care home assurance and our care at home and community health groups. The chart teams continuing to make good progress to complete residents' care home reviews, and they have a very flexible plan in place to do that in terms of responding to service users and care homes' needs. And support continues to be provided to care homes, and over the period of October to December 21, the team completed 48 care assurance visits. So in conclusion, it's a report that's providing a summary of the relevant oversight arrangements, and committee is asked to consider and comment on the contents of the report as noted at 2.1. And I'm happy with colleagues here today who are members of the various groups to take any questions. Thank you.
Thank you very much, Suzanne. I really found that report so helpful. The update of the range of work in the various committees and the work reading on the recommendations of the Adult Support and Protection Inspection. I note the work on the ADP as well, and it's a good. I noticed a couple of points about good to have a number of people in posts or recruiting for posts around key activities. So I think the report just is so helpful, and I'm going to open it up for questions. I don't have any specific questions, but I just wanted to acknowledge how helpful it is. Does anyone have any questions on the report or any of its contents? Well, in that case, I just want to say thank you. Thank you for the report. As I said, it's really, really helpful, and I look forward to future reports. Okay. And moving on to the next agenda item is the HSEP complaints and feedback performance report. Is that yourself again, Gordon?
I think it's a double act, myself and Amanda. Amanda's joined us.
Yes,
so,
yeah, there's
Yeah.
I've got an A instead of an M for Mandy.
I definitely prefer Mandy.
Thank you.
Yeah. I'll kick off, Mandy, if it's okay. I'll kick off with the social work part of it, and then you come in with the. Yep, good. Okay, thank you. So, members have the report in front of them, and I suppose the key point I would like to highlight is that over the last 9 months, we've seen quite a substantial improvement in the response, particularly around the stage 1 complaints. So going back down to the table 2, you can see that the stage 1 complaints for the last 9 months from April 2021 are now at 78%. In previous meetings, I've said, look, you know, we've seen improvements quarter on quarter, but we're not convinced yet to say that it's a trend. I think over 9 months, that improvement in performance does show that we have significantly raised the response times, improved the response times, you should say, for stage 1 complaints. The picture with stage 2 complaints isn't quite as good. Obviously, you can see there we're only at 60%. There are a small number of stage 2 complaints, and a smaller number, I should say, of stage 2 complaints. By their nature, stage 2 complaints are the more complex ones. It's where stage 1, either because of the complexity, there hasn't been a stage 1, or there has been a stage 1 complaint, but the complainant has been dissatisfied with the response. So they are, on the whole, much more complicated complaints to deal with. Nonetheless, we will continue to strive to do better. We'll go back over look at the improvements that we made roughly this time last year that we implemented, and see if there's anything else we can learn to do better to improve that, both figures, both the stage 1 and stage 2 figures. You'll also see that there is one complaint with the SPSO down at, sorry, I'm just scrolling through it, down at table 4.15. Again, very complex complaint requiring the SPSO on this occasion to get independent advice. We will give you a further update when the SPSO have had a look at that advice and come back with their views on that. Happy to answer any questions on the social work side of things, but I'll hand over to Mandy just now.
Good morning, everybody. I'll just draw your attention to 4.10 of the report. And between April and December, the partnership received 16 complaints. 5 of them were dealt with at stage 1 with 100% performance. During the same period, 11 were dealt with at stage 2 with a 63.6% performance, which all in all gives a joint end of year performance of 75% at the moment. The top themes for between April and December, the top 3 continue to be clinical treatment, attitude and manner, and waiting times for an appointment. The good news is that overall